So in this lecture, we're going to cover alterations in collagen and elastin and dermatopathology. Here are the list of topics to include today. Starting out with lichen sclerosis. So as we know, lichen sclerosis is commonly occurring in the anogenital region, more commonly in females than males. You can see extragenital lichen sclerosis at atrophicus in approximately 10% of cases. Over here in the clinical image on the right, you can see this porcelain white atrophic kind of scar-like plaque around the vaginal region. You can have oral involvement, and two peak ages occur with lichen sclerosis. There are the premenarchal peak and the menopause peak. So we can see it in a variety of ages. What we want to do is treat this with high potency topical steroids because complications include squamous dysplasia and carcinoma, unfortunately. On histopathology, you're going to see this classic atrophic epidermis with a so-called homogenization of the upper dermis here. And then depending on what stage of inflammation, you may see mild to moderate or even more robust lichenoid infiltrate right below the area of homogenization. Now, if it's in early evolving lichen sclerosis, you may see a dense lichenoid infiltrate obscuring the dermal epidermal junction. And it may be difficult to tell the difference between evolving lichen sclerosis at atrophigus and evolving lichen planus. So close clinical correlation and follow-up are going to be absolutely recommended in those cases. Here on the left panel, you can see an interface change with baculation along the dermal epidermal junction. You can see that the epidermis is not as atrophic in this area and that you also have lymphocytes that are pretty high up in the dermis. So this is evolving. And as you progress, you have a lot more atrophic epidermis, a really obvious homogenization of the upper dermis, and a dense lichenoid inflammatory infiltrate below that area of homogenization. So just keep in mind that with lichen sclerosis, you can have a stage of evolution between early and more advanced. For test taking purposes, I doubt that they'll show you something that looks like evolving lichen sclerosis versus lichen planus. They're just going to test to make sure that you know the classic presentation of a more evolved lichen sclerosis. So epidermal atrophy, dermal homogenization, and a dense lymphoid band that appears lichenoid. Some people may call this pattern a red, white, and blue pattern. So this is what I was talking about with early lichen sclerosis versus lichen planus. So this image just shows you a dense lichenoid infiltrate. You've got some dyskeratotic cells, some exocytosis of lymphocytes, some areas of obscuring of the basement membrane, maybe a little bit of atrophy, but you also have some wedge-shaped hypergranulosis, some hyperkeratosis. So it may be very difficult to tell early lichen sclerosis versus lichen planus. And if you have this situation, it's just good to put both possibilities out there and say close clinical follow-up and correlation is recommended. You could treat with topical steroids nevertheless, because if you're able to help the symptoms or slow the progression, that would be ultimately the best thing for the patient. Now, eventually lichen sclerosis at atrophigus will evolve to look completely different clinically than lichen planus, so that will be helpful as well. Also, patients may develop extragenital lichen sclerosis, which is not going to look at all like lichen planus, so that will be helpful in the diagnosis. Chronic radiation dermatitis is mentioned here because it can actually look quite similar to lichen sclerosis at atrophigus, but also, I mean, at least histopathologically, but also it's because we're talking about alterations in collagen and elastin. So this fits in this lecture. You can have acute radiation dermatitis and chronic radiation dermatitis. So with acute radiation dermatitis, this typically happens within 6 months of exposure. You see redness, swelling, hair loss, blistering, plus or minus ulceration, depending on the severity. And after years after the exposure, this is considered chronic. And what you'll have is epidermal atrophy as well as scaling, some dyspigmentation, whether it be hypo or hyperpigmentation, some telangiectasia, as well as alopecia in the area. Here's an example of kind of a more chronic radiation dermatitis. You can see that you've got some reactive epidermal acanthosis in the area, some intermittent hyperorthokeratosis and perikeratosis. If there's been some breakdown of epidermis in different planes of section. You might get some leakage of or extravasated red blood cells and serum components within that stratum corneum. Some dilated blood vessels or telangiectatic blood vessels in the superficial dermis, as well as this kind of diffuse parallel running collagen, maybe some fibrosis as well. And then eventually you can even see some sclerosis or what looks to even mimic the homogenization that you see in lichen sclerosis at atrophigus. On higher power, what you'll see are these abnormally shaped fibroblasts, these so-called radiation fibroblasts, and that will help set it apart from lichen sclerosis if you don't have any clinical information on an exam. You'll also see more telangiectatic thin-walled vessels within the area as well. Morphea is actually considered a broad term that encompasses groups of diseases that show sclerosis of the dermis. You may see some loss of the subcutaneous fat, and you may see skeletal muscle involvement as well. It peaks in young adults, but you can see it in patients 20 to 40 as well. It does occur more in females than males on average, and it's usually self-limited. So many times we may see this and it's already burned out, but you can see in this clinical image a nice erythematous rim to the side of this more porcelain white scarred classical burned out clinical appearance of morphea here to the upper left. So if you were to biopsy the center, you would probably see this kind of very sclerotic dermis, whereas if you biopsy the erythematous edge, you may not see as much sclerosis in the dermis, but you may see more inflammation, especially surrounding eccrine glands, surrounding some adnexal structures, present at the deeper part of the dermis as well, at the level of the subcudermal interface. So depending on where you select the biopsy, you may see completely different things. And if you're unsure of the diagnosis, I would recommend biopsying the center burned out lesion as well as an erythematous edge. You can have a plaque form, mostly occurs in adults, females greater than males. You can see this multiple round oval, sometimes peritic plaque can exist on the trunk and extremities as well as the face. Linear morphea can occur mainly on the extremities and on the chest, but also in the frontal parietal region. That's called in coupe de sable. Guttate morphea, generalized morphea, morphea profunda, and disabling pansclerotic morphea are also other forms that you may see. Morphea profunda, as indicated by the name profunda, which may kind of remind you of lupus profunda, but you think of a more deep set morphea within the tissue. Scleroderma or systemic sclerosis, it's difficult to tell on biopsy morphea versus scleroderma, especially if you're biopsying a burned out sclerotic dermis. So keep that in mind that many times these are practically signed out as sclerosing dermatitis, consistent with morphea or systemic sclerosis or localized scleroderma, depending on what clinically you think is going on. Clinical correlation will be essential to be able to kind of make that diagnosis. The sclerosing dermatitis pattern may be the top line, but there may not be as much inflammation as you would expect if you see the word dermatitis, and that's because it can be very burned out as well. So in the comment, there should be some kind of description about how much inflammation there is as well. You can have diffuse or limited scleroderma. So diffuse scleroderma, we're talking about widespread cutaneous lesions and visceral involvement. You can see Raynaud's phenomenon. You can see acute process with fatigue, weight loss, and arthralgias. This is typically associated with autoantibodies, anti-SCL70. And unfortunately, this has a poor prognosis. When we're talking about limited systemic sclerosis, we're talking about crest syndrome in particular. So calcinosis cutis is often seen, as well as Raynaud's phenomenon. Esophageal dysmotility, sclerodactyly, and telangiectasia. There's your acronym CREST. This is more often associated with anti-centromere antibodies, and it has a better prognosis. So you'll remember all of that from step one. So you can see here, patients have decreased oral aperture. They've got some tightening of the skin as well. Here you see these kind of sausage digit appearances, very kind of swollen and restricted movement, very tight skin. You can imagine decreased perfusion or fluctuation in temperature as well. So Raynaud's phenomenon. And you can see this digital clubbing or the clubbing of the nail as well. And I will say that clinically, although we don't have a picture of it in these slides, the activity often correlates with diffuse cuticular hemosiderin deposits along the cuticle there, just distal to the proximal nail fold. So definitely use your dermatoscope to look for hemorrhage there, because that can show you how active systemic sclerosis is in the patient. So Morphea / Scleroderma we're mentioning here because they can look very similar, but you see on the left is a more inflamed picture. So you've got superficial and mid and deep multifocal dense lymphocytic inflammation around eccrine glands, around adnexal structures at the level of the dermal subacute junction as well. And as you progress, you're going to start seeing a thickening of collagen bundles, a loss of those white spaces in between collagen bundles, and a true sclerosis of the dermis. Sclerosis is different than fibrosis. So sclerosis means that you have a lot of collagen that's thickened and not as many cells around. The density of the cells is quite low. The cell nucleus just disappears after the cell completely disintegrates from lack of perfusion of tissue fluid and nutrients and oxygen from surrounding blood vessels that are also pretty much obliterated. Fibrosis is where you've got increased collagen, but you also still have a good amount of cells. The cell density of fibroblasts is actually normal to a little bit decreased, but not as drastically decreased as in sclerosis. Chronic graft versus host disease, you can see in patients that have had a bone marrow transplant or other type of organ transplant, more commonly seen in patients with bone marrow transplant. However, you can see it in a solid organ transplant as well. I like to remind the students and residents that GVHD can present in multiple ways. So if it's acute GVHD, and typically if it's happening in less than 100 days after the transplant, then you may see something that looks like a drug reaction, maybe just a morbilliform drug reaction clinically. It also mimics pretty much any rash in dermatology. So you may see, as you evolve over time into a chronic state, you may see lichenoid GVHD, you may see sclerosing GVHD. And GVHD can truly present as even a bullous disease, depending on if it's an acute eruption. You may have diffuse destruction of keratinocytes causing blistering and bullous eruption, hemorrhage as well. So it can present as a blistering eruption. So keep in mind that GVHD needs to be high on the differential diagnosis of anybody who's had a transplant and is developing a rash, because it can really present in so many different ways. So GVHD can affect the skin as well as the eyes, can affect the oral cavity as well as the GI tract and the liver. It can be de novo or following acute GVHD, chronic GVHD rather. And the lichen planus-like or Sclerodermatis-like GVHD are the most two common presentations of chronic graft versus host disease. But keep in mind that you can just have, as mentioned in the second bullet point, development of chronic GVHD without ever having acute GVHD in the patient. So always be on the lookout for GVHD in transplant patients. And that's one of the most common consult questions we get as dermatologists is this GVHD or not? So in dermatopathology, our goal is to make sure that we're not dealing with GVHD. And oftentimes we have to say that it's something that we cannot rule out and that we highly suspect based on the inflammatory patterns that we're seeing. There's no amazing marker for GVHD in dermatopathology at this time. However, there have been some candidate proteins studied, and the literature is a little bit thin right now and still in its early stages of what is a great, reliable marker for GVHD. It really comes down to histopathologic analysis as well as clinical correlation at this point. Usually you'll see chronic GVHD at 8 to 18 months post-transplant. But again, like I said, you can see it pretty early, and even just within 3 months, the 100-day mark is kind of that traditional time point to divide early or acute versus chronic GVHD. You can see in this picture, this kind of, it almost looks like lichenoid in some areas and sclerosing or scar-like in other areas with dyspigmentation here on the breasts of the patient. So in GVHD, what you can see is maybe in this case, this is more of a sclerotic GVHD because you have very low numbers of nuclei within the dermis with dense collagen fibers. You may see some areas of just vacuolar change along the basement membrane as well. Here you can see a dyskeratotic or apoptotic keratinocyte right here. And there are some lymphocytes that surround these areas. This is the so-called satellite cell necrosis, but I don't rely on this feature at all. It's not entirely specific for GVHD. But when you're looking to rule out GVHD, all you really need to say that you can't rule it out and that you do suspect it is vacuolar change, which may be pretty sparse, as well as apoptotic or dyskeratotic keratinocytes. Now you can have different grades, and this might be considered a grade 1 if that's all you're seeing. But as you progress with the number of apoptotic keratinocytes and dying necrotic keratinocytes, then what you'll see is an increase to grade 2, grade 3, and by the time that you get a bulla formation, because there's so much severe necrosis of the epidermis, that's grade 4. Moving on to eosinophilic fasciitis. So eosinophilic fasciitis is a condition where the patients have painful tender stiffness and induration of the dermis. In fact, here on the right, this almost looks like the prayer sign in diabetes where they can't close their hands. But even in eosinophilic fasciitis, the skin becomes so tense that they can't close their hands. This occurs approximately equally in males and females and adults, affects the forearms, legs, trunk, neck, and hands, but usually not the face. It's associated with fever and malaise, as well as hematologic abnormalities, including polycythemia vera and T-cell lymphoma. You can see blood eosinophilia and hypergammaglobulinemia as well. And there is an eponym known as Schulman syndrome for this entity, eosinophilic fasciitis. You can see this kind of groove sign within their arms as well that we don't have pictured here, but look in the Bologna textbook and online at the various derm atlases to look at the groove sign. It's very helpful to make the diagnosis. So eosinophilic fasciitis, you have to get down to the fascia, obviously, as the name implies, but you see this very dense sclerosis and fibrosis of the fascia plane itself, lots of inflammation as well. And you may or may not see eosinophils within the tissue. You can see more often blood eosinophilia than you're going to see eosinophils in the tissue. So don't rely on eosinophils, rely on the location and the thickness of the fascia with diffuse fibrosis. And you can really understand the clinical correlation here if you're imagining that down to the fascia, they've got such thickening and fibrosis, restricting mobility clinically. On higher power, like I said, you can see a mix of maybe some sparse eosinophils, but mainly it's going to be more lymphocytes, histiocytes, maybe some plasma cells as well. Remember, there's association with hypergammaglobulinemia, so plasma cells may be being produced by these, or immunoglobulins rather, may be being produced by these plasma cells. Moving on to elastosis, perforans, serpiginosa. As you can see, this kind of annular or serpiginous plaque present on the patient occurs in young adults, males more than females. You see papules with a kind of within this serpiginous pattern here. It can occur on the back, the sides of the necks, the arms, really anywhere, honestly. And has many different associations. Some of the more famous associations include Down syndrome, Ehlers-Danlos syndrome, and penicillamine. However, you can see it in Marfan syndrome, as well as I mentioned, Down syndrome, the penicillamine-induced associations as well. Osteogenesis imperfecta, you may see it in that, as well as Rothman-Thompson syndrome, and then, as I mentioned, Ehlers-Danlos syndrome as well. You could see it in scleroderma. There are many different associations, so many different acronyms out there you may find in different textbooks, but at the end of the day, the clinical appearance and the histopathology are going to help make the diagnosis. So here you can see this perforating kind of eosinophilic to basophilic mixture of the material as the elastic fibers are being actually perforated through the skin. And this is Verhoff and Giesen stain to really highlight those elastic fibers being pushed up through the superficial dermis and out through the skin, or up through the skin. Now, if you think about these little plugs that you're seeing, that is where the perforation is truly reaching its peak clinically. So always think about the clinical pathologic correlation, what you're seeing under the microscope, and how does that translate to what you're seeing clinically. Reactive perforating collagenosis, also a very common and very related entity, perforating disorder. It's pretty rare. I would say it's rare in the general population, but it's very common when you're on consults and you're in the hospital and you've got patients that may have renal failure. They're very itchy. They're scratching their skin a lot. And what you have is this reaction to mild trauma. So the damaged collagen is actually extruded through the epidermis. And these lesions look more umbilicated as opposed to more rough, lichenified, lichen simplex chronicus or prurigo nodularis. So that's what's going to separate it clinically and even histologically. When you're looking clinically, it looks really smooth and like you've got these plugs here. And so that's going to be the difference between a prurigo nodule and reactive perforating collagenosis, both clinically as well as histologically. We'll look at the pictures. So it looks more umbilicated. It's got some keratinous debris. It may be sporadic or it may even be inherited. In fact, the inherited form is called Curley's disease. The eponym is usually referring to some kind of inherited predisposition. So usually it can present in childhood, but if it's acquired, it's going to be associated with renal failure. So this is the classic image that you'll see, this not extravasation, but extrusion of basophilic and eosinophilic material. It kind of has a spectrum of more pink to more purple to dark purplish blue staining. And you see that it's coming right through this opening in the epidermis here. So it's really just perforating out through the epidermis. To the adjacent side, you see this acanthotic epidermis, but in the center, you don't see the hyperorthokeratosis and the acanthosis of the epidermis with elongated reedy ridges like you would see in a prurigo nodule. So this is more consistent with reactive perforating collagenosis. Also, in trichrome stain really kind of highlights the collagen being extruded throughout the epidermis. You can see the epidermis here, and then these blue fibers kind of reaching up to the top. What's the differential diagnosis of perforating disorders? So as we talked about reactive perforating collagenosis, and that being very similar to Curley's disease. I think I accidentally mixed that up there earlier on the slide where I said that Curley's disease is more associated with childhood, but in fact, it's the reactive perforating collagenosis that's considered more associated with childhood. And then Curley's disease is kind of this, you're going to see this more average age of 30 years, 20 to 60 years old. And in fact, there's a lot of similarities between reactive perforating collagenosis and Curley's disease. It can be a little controversial and difficult to separate them out because both Curley's disease is acquired as well as reactive perforating collagenosis can be acquired in patients as well. So generally in reality, it's just kind of diagnosed as a perforating disorder, especially if the patients have associated diseases like diabetes, renal failure, hepatic insufficiency, congestive cardiac failure, et cetera. So with Curley's disease, typically it's been diagnosed in patients average age of 30, between 20 and 60, and could be present in both males and females. You'll often see this on the extensor lower extremities, the upper extremities, the head, neck, and trunk. You can see a Kebner phenomenon occasionally in this entity. And as I mentioned already, the associated diseases, the mode of inheritance is not technically considered genetic, as I erroneously mentioned in the last slide. And histologically, there's transepidermal elimination of the degeneration of the perikeratin and inflammatory debris. So this is elimination of debris that will often stain pink and purple. And it's difficult to really tell the difference between that and transepidermal elimination of collagen, which again, you can see as basophilic, eosinophilic. There's a lot of cellular debris. There's some serum containing material in there. So it's difficult to really separate those two on histology and for all intents and purposes. Reactive perforating collagenosis, or often purely you would see in childhood. It can be in males and females and occur on the upper and lower extremities in the face. It is positive for Kebner phenomenon more often than Curley's disease. And the classic reactive perforating collagenosis is no association. However, what we mentioned earlier is acquired variance is often associated with renal failure. Now, separating that out from Curley's disease is going to be pretty difficult. There's several different literature reviews on this topic that if you're more interested, you can kind of delve into those as well and see some of the controversy behind it. Mode of inheritance, maybe autosomal recessive, maybe autosomal dominant. And as I mentioned, transepidermal elimination of collagen on histology. Remember the elastosis, perforans, serpiginosa, most commonly present in the second decade, but as you saw, so many different associations. You could see it in all ages. Of course, it can be present in males and females as well, occurring clinically on the side and back of the neck, upper extremities, face, and lower extremities. Occasionally positive Kebner phenomenon and associations, as we mentioned, Down syndrome, Ehlers-Danlos, osteogenesis imperfecta, and pseudoxanthoma elasticum, as well as penicillamine associated. Histology, you will see that transepidermal elimination of abnormal elastic tissue. And then finally, perforating folliculitis, more commonly in the third decade, however, both in males and females. Hair-bearing portions of the arms, forearms, and thighs. This usually does not have a Kebner phenomenon and really no cleanly associated diseases with it. What you'll see are areas of intrafollicular curled up hair on histology and transepidermal elimination of degenerating connective tissue. So moving on to keloid, extremely common in dermatology. You need to be able to recognize what it looks like on histology. So keloid is an exuberant scar formation. The definition is it forms beyond the site of the original injury, as opposed to hypertrophic scars, which usually are contained within the original scar bounds, usually related to direct trauma in patients that are predisposed to develop keloids. We often see this in teens and young adults, especially around the earlobes after ear piercing. Patients who have higher Fitzpatrick skin types, like types 3, 4, and 5, for example, are even more prone to it, African-American descent, et cetera. But really patients of all backgrounds of ethnicity and race can develop different types of presentations of keloids. So on histology, you can actually see this is kind of a nodular formation where you see these long whirling fascicles of fibroblastic proliferation. But when you go in higher power, you'll see these really thicker bubblegum collagen areas, as they call it. So very thick and eosinophilic fibers that are essentially qualifying this entire lesion as a keloid. But if you didn't see these bubblegum-like fibers, then it may be more consistent with hypertrophic scar on histology. So again, the difference between hypertrophic scar and keloid really comes down to the clinical behavior of it, but you want to see these thick bubblegum-like eosinophilic collagen fibers to truly call it a keloid on histology. Hypertrophic scar, as we mentioned, you see this hypertrophic plaque within the area of the original scar. Hypertrophic scars can look like unexplained pink papules with overlying telangiectasia and often be confused clinically for basal cell carcinomas as well. So you see these on the head, neck, chest, knees, and shoulders. There's really no racial predilection. It can occur really in many different types of Fitzpatrick skin types or ethnicities or racial backgrounds. How do you tell it from a keloid clinically? So this does not, as I said, extend beyond the boundaries of the initiating injury. So clinically, there's a definition of hypertrophic scar versus keloid. And you can see similarities with the keloid where you've got these nodular proliferations of fascicles, fibroblastic cells, and vertically oriented vessels can be seen as in a normal scar as well. So it looks like a normal scar, but more robust in terms of its fascicular nodular pattern. You also see the epidermis overlying the scar has a loss of the reedy ridge architecture. On higher power, you see a fibroblastic proliferation. You do not see those thick bubblegum-like collagen bundles. So you can see hypertrophic scar-like material around keloid. And so if the clinician says rule out keloid and you don't see it, you might see it on deepers or in different sections of that bubblegum collagen. Otherwise, you're just going to see hypertrophic scar. Now, if they say it's clinically a keloid, what I'll do is sign it out as hypertrophic scar consistent with clinical diagnosis of keloid, because again, the clinical diagnosis suggested that it's overgrowing the bounds of the original scar. So even if you don't see those bubblegum collagens, you just may not be in the plane of section to see it. You can do deepers if you really want to, but at the end of the day, the clinician is just really removing that for the patient, submitting it for pathology. On your exam, what you're going to want to see to make the diagnosis of a keloid is this thick bubblegum collagen. Acne keloidalis nuchae presents usually on the back of the neck after inflammation and promotes scarring in this area. You see scarred up papules at the border of the posterior scalp hairline down to the kind of the superior to mid neck here. It more often occurs in patients with higher Fitzpatrick skin types, type 3, 4, 5, 6, etc. Common in patients with African American descent, especially in men, on the nape of the neck. It starts as localized follicular papules that can increase in size, become confluent, maybe some keloidal plaques with hair loss as well. You can see these areas of retained hair shafts surrounded by kind of concentric fibrosis and some scattered lymphocytic as well as neutrophilic inflammation. This is a scarring alopecia. And so really what you do have are loss of, here you see a retention of a follicular unit, a pilosebaceous unit, but eventually you lose these. So to the left, that's probably the clinical papule, and to the right may be a normal or preserved, but almost overtaken follicular pilosebaceous unit. Fabry-Rocachot syndrome, you should know this. It could show up on the exams, but you'll see this a lot clinically. It's a clinical triad of cysts, comedones, and elastosis, especially on the face, around the eyes, and the cheeks of patients who've had a lot of sun damage, prolonged sun exposure throughout their life. Now, they come in and they're curious, is this a cancer? Is this a basal cell? What's going on? So, and I will caution the clinicians, especially, and the dermatophathologists, that we've had patients that have had biopsies within the clinically classic Fabry-Rocachot that have turned out to be hovering basal cell carcinomas. So you can definitely have collisions between Fabry-Rocachot and non-melanoma skin cancer, or even melanoma for that matter. So if clinically it's progressing, doing a biopsy and looking for a skin cancer that may be pushing up through or in and amongst the classic Fabry-Rocachot lesion is going to be advised. So this is what might show up on your exam, is this kind of superficial cystic collection. So you can see this keratinaceous debris dilating the follicular ostia here. So really kind of small milia-like cysts all juxtaposed to each other in the superficial part of the specimen. And you can see how that correlates clinically with these milia-like cyst collections. Acrodermatitis chronica atrophicans. This is a chronic stage of Lyme disease. It's more common in Europe. The organisms that you should remember are Borrelia azeli in Europe or Borrelia burgdorferi in the USA. You can see this kind of hyperpigmented to kind of violaceous central part of the change of the skin, and then it kind of has a concentric pattern as you move outward. Now, the word atrophicans suggests that you're going to have some atrophic epidermis as well as diffuse inflammation. It can actually be mixed lymphocytes, histiocytes, plasma cells, and even some eosinophils. You might see some dilated vessels, some ectatic vessels, as well as maybe some eosinophilic collection around the vessels as well. Anetoderma is very common, especially in young adults. You may see this in peaking around 20s to 40s, more common in females to males. You may see this in the upper trunk and proximal arms. Anetoderma presents as numerous foci of atrophic or wrinkled skin. And in fact, if you press the surrounding skin, the Anetoderma papule may go from a depressed state to a protrusive state. So that may be one way to test clinically for Anetoderma. What's the cause of Anetoderma? So primary, it arises in previously normal skin. You have kind of loss of extracellular matrix proteins, which causes a weakness in the dermis, allowing for protrusion of the skin. Secondary arises in the site of a previous lesion. So on histopathology, you can see Anetoderma looks kind of normal if you just look at the H&E biopsy, but on histopathology, you see a drastic decrease in the number of normal elastic fibers within the dermis. And so that kind of loss of elasticity and normal extracellular matrix component within the dermis allows for just kind of a depressed or even protruding papule clinically. Atrophoderma, on the other hand, usually occurs in patients in their 20s and 30s on peak. So very similar to the age of Anetoderma, much more common in females than males. And what you see are these gray-brown violaceous depressed macules. And how we describe this clinically is a cliff drop border. So you can see bilateral or symmetrical presentation on the extremities or lower back, even the trunk. And it can coexist with lichen sclerosis, Morphea, or even Scleroderma. And so here you see Anetoderma just has this kind of nondescript collagen. And again, you see there are some focal preservation of the eccrine glands. But as you go from the panel, the left to right, you can see that the dermis is getting thinner, that there's less sebaceous units, maybe a little bit less of the eccrine structures, but the thickness of the dermis compared to other areas is much less. So you have a change or an atrophy of the dermis, so atrophoderma, as they call it. But it's really a clinical diagnosis. It's going to be hard to make this diagnosis on histopathology alone. Now, if they say rule out atrophoderma, it would be a good idea for the clinician to get you part of the normal skin as well as the atrophoderma lesion itself. So that cliff drop, so you can really see the cliff drop, not even just clinically, but also histopathologically. That would be the ideal sample if you're really wanting to prove this. And lastly, aplasia cutis congenita, just as it sounds, you have decrease or aplasia development of the skin and basically a congenital development. So it's a congenital absence of skin in certain areas. We often see it on the scalp. It could be focal or widespread, affects several different groups. In fact, there's many different ways this can present, but the prototype presentation is going to be on the posterior scalp lesion, and it heals by scarring. So the purpose of this topic and this presentation is not to go through all the different ways it can present, but really just to kind of show you the histopathology. So you can see a drastic change from the upper left part of the epidermis where you've got some pilosebaceous units, some follicular units, but they look pretty superficially located because these anagen hair follicles are actually within kind of a sub-Q region, but the overall thickness of the skin is quite decreased. And then over here to the right, you just kind of have this granulation tissue and necrosis and complete absence of pilosebaceous units and adnexal structures. And underlying that, you also have just diffuse fibrosis within the tissue. So this is how this kind of clinically correlates. If you were to biopsy this area over here, you get some of the hair, but then as you go to the really aplastic area, you're going to see a transition from the hair to the really aplastic area, and all underlying is fibrosis, which you can see this kind of scar-like appearance to the lesion. So that is your clinical correlation for this entity. And that is it. So thank you for your attention.